Continuing on with 36. So mechanical ventilators are used with patients who can't breathe by themselves. If the ventilator malfunctions, take the patient off the ventilator, apply a tracheostomy collar, and then ventilate them just with a BVM. If it's something that can be troubleshooted by either the patient or the caregiver, you can try that as well, but you're going to need to bag them manually for the majority, if not all, of your transport. Apnea monitors are used with infants who are premature, have really, really bad gastroesophageal reflux that causes coughing or choking episodes, have a family history of sudden infant death syndrome or SIDS, and then who have experienced a life-threatening event. Usually were used for or at about 2 weeks up to 2 months after birth, and just monitors the respiratory system. It will let a sound out if the infant experiences bradycardia or apnea. Since kids, most of the time, anything cardiac is going to be directly related back to airway and breathing. Hypoxia can cause some pretty interesting things within the body of a newborn. And so if the heart rate starts going down, even if the patient's still breathing, it's still going to let you know. If at all possible, try and bring that monitor to the hospital with you. Pacemakers. So this is a device that's implanted under the patient's skin to help regulate their heart rate and or rhythm. It may include an automated implanted cardioverter defibrillator, an AICD, which monitors the heart and then also can shock it when it's not doing what it's supposed to be doing. We're not going to put defibrillator pads directly over top of those. They're pretty easy to recognize. They're smaller than a deck of cards, generally going to be rounded or ovaled, but it's going to be right up underneath a big flap of skin on the front side of the chest. Try and gather as much information about that pacemaker as you can during your history taking so that you're familiar with why they have it. Left ventricular assist devices, LVADs. This takes over function for either one or both of the ventricles of the heart because they're no longer efficiently beating. It's typically used as a band-aid or a crutch to get somebody from severe issue to at least stable while the patient waits for a heart transplant. But this may be more so permanent for somebody that doesn't qualify for a heart transplant as well. It may be difficult to actually palpate a pulse in someone who uses an LVAD, so just assess overall perfusion pattern. There's not a whole lot we're going to do for an LVAD. Again, the patient's far more trained than we are, so ask them about it. External defibrillator vest. This is a vest with built-in monitoring electrodes and defibrillation pads. It's worn by the patient under their clothing, so oftentimes we won't know they have it unless they tell us. Attached to the monitor provides alerts and voice prompts when it recognizes a dangerous rhythm and before it delivers a shock. If the patient's in cardiac arrest, we do want to make sure to leave the vest in place unless it's going to interrupt CPR or interfere with compressions. Central lines, depending on what kind they have, a catheter is placed in the vena cava to provide venous access. It's used for several different situations, so those on chemotherapy, those on long-term antibiotics, drug therapies, and pain management, total parenteral nutrition or TPN, and then there's just a whole host of problems why they may end up having a central catheter in place. Here's what it's looking like to draw blood from that central catheter. Truthfully, if you're not trained on how to adequately do this through an EMS agency, etc., we're not messing with central lines. Even myself as a medic, I find myself very hesitant when we're talking about having to care for a central line. Gastrostomy tube, often referred to as G tubes or gastric tubes, they're placed in the stomach for a patient who can't ingest fluids, food, and medication by mouth. May be inserted through the nose or the mouth and then down into the stomach. These are called nasogastric or orogastric tubes, depending on which orifice they start in. They may be placed surgically and deeply into the stomach through the abdominal wall, and there's a picture of that here in just a moment. They may become dislodged during the patient's just normal day-to-day activities, which then immediately stops the flow of fluids. So we want to assess for signs and symptoms of bleeding, just to make sure that all is well. And then we want to stop any of the fluids that are going in if it becomes dislodged. So here's a picture of a surgically implanted gastrostomy tube. There is an increased risk of aspiration, so we need to have suction readily available, and we want to try and elevate their head at least 30% or 30-degree incline so that they don't end up aspirating. Shunts are for patients that have some sort of chronic neurologic condition. It's basically a tube that drains excess cerebral spinal fluid. There's a ventricular peritoneum shunt, which drains that excess CSF from the ventricles of the brain into the peritoneum of the abdomen. And then there's a ventricular atrium shunt. This decreases CSF from the ventricles of the brain into the right atrium of the heart. For our palpation, it's very likely that we're going to feel a fluid reservoir beneath the skin on the side of the head, right behind the ear. If for some reason the patient ends up contracting an infection, they may have some pretty quick changes in mental status, and respiratory arrest may occur very quickly. Oftentimes when you see an infection, it's going to crop up within 2 months of insertion, and there's going to be various signs of distress. A lot of it is going to be an altered mental status, headache, nausea, vomiting, that sort of thing is going to clue you into that. Vagus nerve stimulators are used to treat seizures that are not well controlled with medication. It stimulates the vagus nerve to keep seizure activity from occurring. It's located underneath the patient's skin, and its size is relative to that of a silver dollar. Colostomy or ileostomy. This is a surgical procedure that ends up creating an open between the small or large intestine and the surface of the body. It allows for elimination of waste into an external bag or pouch, which is then emptied and or changed frequently. You want to allow for signs and symptoms of dehydration if the patient has been complaining of diarrhea or vomiting. The area around the stoma is very prone to infection, so keep an eye on that. Urostomy is a surgical procedure that connects the urinary system to the surface of the skin. It allows urine to drain through the stoma in the abdomen wall instead of through the urethra. Patient assessment guidelines. Interaction with a caregiver or adult or child with special needs is an important part of our patient assessment process. Oftentimes, the family has been caring for the patient far more than anybody else has on a more consistent basis, so they tend to know what's going on. Determine the patient's normal baseline for assessment because you don't want to have any biased thoughts in your head. So again, asking what's different today that you felt the need to call 911. For home care, is any care that a patient receives while in their home environment. Represents a spectrum of special health care populations. So this could be infants, older adults, patients with chronic illness, patients with developmental disability, services such as home meals, house cleaning, laundry, yard maintenance, physical therapy, and then personal care. It's possible that we could get called to the residence of a home care provider and it's necessary that we receive all of the documents that we need to. Sorry. Hospice care and terminally ill patients. Terminally ill patients may receive hospice care at a hospice facility or within their home, and that's becoming more and more popular. Somebody that's going on hospice care typically has about an estimated 6 months or less to live. A lot of times they have diseases such as cancer, heart and lung failure, end stage Alzheimer's disease, and AIDS. Most patients have a completed do not resuscitate order or DNR. They may have medical orders for what they do actually want to allow you to do for them. Patients that are on comfort care or palliative care, this is talking more about quality of life. So we're working on improving the quality of life rather than doing treatment to extend the life. Follow your protocol, patient's wishes, legal documents. This can get kind of sticky. So try and remain calm. What we do in these situations are going to leave a lasting impression on the patient's family. So we want to try and help them out. We want to advocate for the patient while still allowing the family to have their say. Poverty and homelessness. So people who live in poverty are unable just to provide for their basic needs, such as housing, food, childcare, health insurance, and then various medications. Disease prevention strategies tend to not be there. So like dental care, nutrition, exercise. The homeless population includes patients with mental illness or prior brain trauma, victims of domestic abuse, persons with addictive disorders, and impoverished families. Make sure that you advocate for all of your patients, irregardless of what's going on with them. We're going to still provide emergency care and transport no matter what's going on. All healthcare facilities have to provide assessment and treatment regardless of the patient's ability to pay. I've had people say, I don't want to go to the hospital, I can't afford that bill. So they can still get life-saving, stabilizing treatment whether they can pay it or not. Other than that, chapter 36.